This is Gopalamurugan. I'm moderating. I have an excellent panel, and the hall is packed. So, stage is all yours, sir. Off you go.
Yeah, yeah. Thank you, Gopalji. And good morning to you all. It's my pleasure to welcome you all to this live case transmission of TAVI from CMC's new super specialty campus in Ranipet. Without wasting much time, I will introduce my team. With me is Dr. Nathaniel Shoaib, Shaktivel, and today's anesthetist is Balaji, Satish, and the team. We also have an excellent support team helping us with the case. Vijay will be crimping the valve along with Megha. Can we have the first slide, please? Next slide. So our patient today is a 77-year-old male who's been diagnosed to have aortic stenosis. He's quite symptomatic. He's NYHA class 3 at the time of presentation to us. His past history is significant for rheumatic heart disease and a couple of open mitral surgical procedures in the past. Last one being a mitral valve replacement in 2013 with a bioprosthetic valve. He also had a pacemaker implantation in 2018 for complete heart block. He also has all of these comorbidities with an STS score being in the intermediate range. As you can see in the image on the right, the chest X-ray shows progressive enlargement of the cardiac sellout. Echocardiography-wise, he's got significant aortic stenosis and regurgitation. His ventricular function is normal, and the mitral valve is also functioning well. He also has moderate TR and pulmonary arterial hypertension. Next slide. So we did his, unfortunately, the slides are not playing here. His angiography showed minus CAD. He has moderate AR on aortic root angiography, and the leaflets are quite restrictive in motion. Next slide. We did a CATS assessment yesterday. Pulmonary artery pressures were quite high. Mean pressures about 39 to 40. The mean transaortic gradient was about 50 to 55 millimeter mercury. Next slide. And this is his CT analysis. As you can see, this is a tricuspid valve with a good sinus of Valsalva diameters. Coronary heights are quite generous. The area-derived diameter is about 22.9. The sinotubular junction diameters, ascending aorta diameters are all quite favorable for TAVI. Next slide. So in this slide, I want you to take a look at the LVOT at 3 mm below the aortic annulus level. You can see a bit of the surgical mitral prosthesis here. And this is the challenging part of the procedure today, to get a good position of the transcatheter aortic valve across the annulus and the LVOT. Next slide. So the distance between the mitral surgical valve and the aortic annulus is about 1.5 millimeters. If this distance is about 7 millimeter or more, you can do TAVI quite safely. But if this is less than 4 or so, then you can face challenges. Mainly, valve can kind of embolize during the procedure. Next slide. His femoral anatomy is also quite clean, hardly any tortuosity, no calcification or no narrowing. Next slide. So when you have a surgical bioprosthesis, the deployment angle you prefer onto the LAO side. This is because the mitral valve will be away from the aortic annulus, and especially the non-coronary sinus. So here we're choosing a LAO of 14 and caudal projection for deployment. Next. So this is the plan. We're going to do a transfemoral TAVI. We usually use one ProGlide, and if needed, we use one angiosil in the end. We're going to use a MyValve octocore device, right femoral artery for the main device. This will be done under conscious sedation without TE guidance. For rapid pacing, we'll use a transfemoral pacing catheter. Of course, we have this pacemaker wire, and there's a possibility of pacing through the vent. But when you have a pacemaker, you can't pace more than 180. We will not do predilatation for the procedure. Usually, if you have a mitral bioprosthesis, it's good to do a predilatation to look for shifts or displacement of the balloon during predilatation. But because there's hardly any calcium, I'm thinking that I will not predilate. And I'm going to use octocore, which is a second generation balloon expandable valve from Merrill. And we also try and use a commercial alignment technique by the Merrill group. Next slide. So using a 24.5 valve gives me about 14% oversizing, and probably will reduce 1 ml volume from this delivery system to give a good final oversizing. The LVOT dimension at the level of the mitral process is about 23.5 or 24. Little tricky for deploying this TAVR valve. Next slide. So these are the difference between the MyVal and Octocore. Octocore is a second generation of the Merrill transcatheter valve. It has got 2 rows of interlacing octagons, and as you can see, it's got a much higher ceiling skirt. And in fluoroscopy above the Octocore, you can see that there's a marker to help you in deploying the valve in a quite stable and predictable position. Next. So we know the need for commission alignment. I'm not going through this slide in detail. So we'll try to take advantage of the octa-align technique. And next slide. This is how we do it. So in the root axial view, you identify the right coronary artery origin. And in this case, it's at about 3 o'clock. And then you crimp the valves such that one of the commissures is at 12 o'clock position. Next. So that's where we are, and let's see how this case pans out. So what we have got here is we actually got access while we are waiting for you. I've deployed one ProGlide. Can you focus on the groin? We've got one ProGlide at 12 o'clock position. I have a 10F sheath, and on the other side, I have a slender and a prelude sheath, which are essentially 4-5 kind of a system. Yeah, so can we do the aortic root angiogram? We are going live now. Yeah, ready? 15, LA 14, caudal 3. Do you have any suggestion on the valve size or?
Yeah. So tell us your choice of valve. Why an octocore? Why not a self-expanding platform, which is forgiving? Just for discussion reasons. What is the reason? Because the distance is low. You were concerned. Why not a self-expanding platform? Just for discussion.
Yeah, that's a good question. Like when you have a mitral prosthesis, many people want to use a valve which is self-expanding, because in case deployment is not good or position is not good, then you can retrieve it. I like balloon expandable valve in this situation because you get kind of a stable and predictable position. Self-expanding valve tend to move during the final release, which can be kind of tricky here. So that's the reason why I'm taking a balloon expandable valve. And if you have to use a self-expanding valve, probably I need a 26 or maybe even 29 valve, which is quite oversized for the LVOT as well. So if you're using a balloon expandable valve, it's either a 23 or 24.5. So we have can you all see the root angiogram? You can see the mitral valve is quite close to the aortic annulus. So we'll try and cross this valve. Yep. LA 45, LA 40. Straight wire.
In general, in rheumatic aortic stenosis, because this patient looks like rheumatic aortic stenosis or a calcific aortic valve.
Was there a question or something?
No, in this patient, is
John,
it a rheumatic
what would be your
stenosis or a
strategy?
calcific
Suppose your
aortic
balloon
valve?
expandable valve just dives in and you have no control and it impinges upon that artificial valve up there. What would be your strategy in that case?
So if there is some damage to the mitral valve, we are actually prepared to do a valve in valve. It's a bioprosthetic valve. If there's any significant MR or MS, we may have to do a transcatheter mitral valve in valve as well. Can you take it out? Usually with balloon expandable valve, what we have done quite a few cases in similar scenarios. Usually valve kind of milks back, and then you get a really good high position. Pigtail. So the only concern is there's hardly any calcium here. Usually when we do these cases, the leaflets are quite calcified, and then the valve gets held very tightly there. Can you come a little earlier? Just want to make sure that we are far away from the mitral valve. Can you just come earlier, some more earlier, nicely earlier, so the virus seems.
Are we meant to go to Medanta and interchange from there? Or, sorry, RHL? Jaipur? Okay, so team, we're going to move to Jaipur and we're going to come back to you once you cross the valve. Is that okay?
Yeah, we actually already crossed, and
we're just going to switch
we are
over to
seeing the
Jaipur and just
gradients,
see what they're up to, and then we'll come back.
Sure, no problem.
Okay,
Sure.
over to Jaipur, please. Please go ahead.
Yeah, so we crossed the valve. We got the hemodynamics on screen. Mean gradient is about 55. So we got the introducer sheath, the Python inside already. Yeah. So we are in the process of crimping the valve. Can you show the delivery system as we take it on the wire? Yeah. It's got the aligners on this or not yet? Yeah. So you have crimped the valve commissures in a 3 o'clock position, right? And you checked with the device. Yeah, can you show that device where you checked that clock phase? Can you zoom it on the? So this is the one we use to verify that the commissures are here on here. Zoom on this black dial. Yeah. So this is a small device which we make sure that the crimping is accurate. So once that is done, with the Merrill logger facing up, we take the valve in. Hold the wire. Yeah, on the wire, please. So here we have the octa-core. You can see an additional marker beyond the middle marker, the proximal end. And that's the landing zone marker. One more mag as we cross the annulus. Yeah, hold it. Hold the wire, please. Nicely stretched. Yeah. One more mag. We'll come this side. Yeah. So among all the valves, balloon expandable, self-expanding, octa-core has the least foreshortening. That's the advantage of this marker. If we position it correctly, the foreshortening is quite predictable. Yeah, can you follow for me? Yeah, let's do a test shot for the position. Cine, 15 at 15. Yeah. Yeah. Set it multiple 15, 15, 15, 15. Yeah, fine. Yeah. Yeah, so this looks quite good for me. So everybody's ready for deployment. Keep it pushed in a little bit, fluoro. Yeah, very slowly we'll do. 200, rapid pacing, on. Cine, as the pressure goes down.
Pressure.
Not yet. Yeah. Keep it there, keep it there. Push in, push in, push in, push in. Keep it pushed in, push in. 1,000, 1,000, 2,000. Spacing off, balloon back. Fluoro. Yeah. Pressures. Yeah. Yeah. Can you come, little Caudal? Can you play the deployment in the meantime? So you can see that the valve remained during the deployment quite stable and didn't move much. And you also can appreciate that the foreshortening is one of the least across the entire spectrum of the transcatheter valves. Fluoro. So this is the advantage of using an octocore in a case like this. Yeah, 035 wire. O35. Take the pigtail out.
Is there any difference in the profile between this, this first generation and the second generation valves, or is it the same profile?
It's the same profile, same introduce the sheath. Yeah, yeah, yeah. Let's do an angio to make sure things are all right. Yeah, yeah, fine. Pigtail a little back. Yeah. Connect.
Is there any added advantage of doing TE guided valve implantation for this type of mitral valve very close to aortic?
Not really, because T doesn't help you at all. I mean,
You can't see anything on TOE
one angio.
to know where you're doing anything.
Yeah.
There'll be a lot of artifact. So fluoro is
Yeah,
probably best.
yeah, very good position. Yeah, yeah.
It looks beautiful there.
Sure. So as you can
Nice,
see, we got a good position. Yeah.
Yeah, the position looks good. Beautiful
so I'll take the
demonstration of
delivery system out
octocore
and-
and the no shortening effect of octocore that was beautifully demonstrated. Excellent. We're going to just switch over to the next lab and we will come back to you shortly. Okay,
Am I
team,
audible again?
we're back here. We've seen your octocore. The stage is yours now for the next 5-10 minutes.
Yeah, sure. Thank you. So just want to show you the final results. We did the angiogram post pulling out the wires. Yeah, it's live, and you can also show the echo on the screen. We evaluated the mitral valve. There's no obstruction or any leaks, hardly any paravalvular leak. Gradients, can you show the hemodynamics? Hardly any gradient. And then we had used, just like Ravindar, one proglide, final angiogram of the groin. And hardly any extravasation. So we're just done with one proglide. And these are our final results.
Great results. Superbly demonstrated. Octocore, beautiful result. Echo and the final angiograms of the peripheral vessels. Anything to add from your lab?
Thank you.
We'll close here.
Yeah, so I just want to say thank you to the Hyderabad Valves coordinators for inviting us for this live case. Also thankful to my support team, Nathaniel, Pratish, Shoaib, Shaktivel, Mayank, and the others for helping out with the case. And
Super.
Thank you again once again.
Congratulations and thank you for the great show.
Yeah, thank you. Yeah, sure. Thanks, Gobi.